Regarding osteochondroma, it is a cartilaginous cap bony projection which arises to the external surface of the bone containing a marrow cavity. Their growth is parallel to the growth of the of the skeleton and stops at maturity. Benign lesion, it can be pedunculate or sessile. Growth stops at maturity. X-ray shows metaphyseal lesion. Cortex and matrix is continuous with the bone. Histology shows mature lamellar bone and herniation of the proximal. Usually this is caused by herniation of fragment of the physis. It is solitary. In solitary cases can be painless. Slow growing in adolescents, commonly around the knee. Excise if it's large and suspected chondrosarcoma. Risk of malignant transformation is less than 1%. Regarding the transformation to chondrosarcoma change from exostosis to chondrosarcoma. Number 1, growing after the age of maturity. Number 2, thinner cartilaginous cap. Number 3, marrow cavity is not continuous with the bone medullary cavity. Osteochondromas always go away from the physis, but if they go towards the physis, suspect a tumor. Number 5, the chondrosarcomas are painful. So if any lesion which is painless before and becomes painful, there is a high suspicion of malignant change. Regarding the cartilaginous cap, if less than 1 centimeter, it's benign. If more than 2 centimeters, it's malignant. I'll point toward multiple hereditary exostosis. It is mutation in EXT1, EXT2, and even EXT3. They can develop radial bowing, elbow deformity, tethering of the fibula, and the sarcomeous risk is 10%. Multiple hereditary exostosis is by loss of Indian hedgehog gene.